Well, this is something that we know for years and years. Now there have been some recent publications showing that at least the population of patients with DGBIs, they show a particular relationship between food ingestion and the appearance of pain or other symptoms, no? And there are very common mechanisms related to that, no? For example, no? In these patients, it has been shown that there is neuroinflammation in the gut, but not only in the small bowel or in the colon. Now there's a huge movement to relate, for example, in patients with functional dyspepsia, the appearance of mucosal inflammation in the duodenum. For example, the mast cells are able to produce molecules like histamine. Histamine is a neurotransmitter, the neurotransmitter with great capability of altering transmission in the gut. Has been related clearly to pain, particularly to pain developed after meals. And this has been also related to the activation of muscles, no? And symptoms. No? There are other mechanisms that have been postulated, is like the one food intolerance, for example, salicylates or some other substances that may be involved, no? Maybe present in food or bacterial toxins or things like that. No? But at the end, in the last year, obviously, the role of the microbiome has been increased, no? In the sense that microbiome now, it is known to produce a number of neuroactive compounds that has been related to nerve functioning, to gut functioning, and some of these molecules are able to regulate also pain. Yeah, so in my experience, they have a good place. I mean, I use them a lot. The thing is that if you go to the guidelines, no, and European, American, Asian guidelines in the last years regarding DGBIs, they don't recommend the use of probiotics, but they don't go against them. No? So recognize that there is a good science behind, and the science needs to improve, and it's up to the physician to use them or not to use them. So it's like a subtle acknowledgement that obviously probiotics and prebiotics, they have a role in the management of these disorders. And in my clinical practice, it's something that I do use regularly, no? Both pre and probiotics, no? And I would say that at the end, you need to know which particular probiotics are useful for certain conditions. In this sense, we have recommendations also for the World Health Organization, and these recommendations are evidence-based, no? So there are many of them that have specific recommendations for their use in gastrointestinal disorders like diarrhea, abdominal pain, or bloating, even bloating, no? And also in infants, no? For the treatment of traveler's diarrhea. So I think you need to have a good knowledge of how to use the probiotics. It's good to connect science evidence to clinical practice. So probably now at the clinical level, at the common practice, is not useful because there's no way. But obviously, we have evidence, no? Several studies, very strong studies, showing that, for example, the response to low-FODMAP diet can be regulated depending on your basal microbiome. No? Also, responses to gluten restrictions or some other diets can be modulated if you know in advance your fecal microbiome. No? In the clinical practice, as I said, it's probably more difficult to do. No? But if you have common sense, I think you can use these microbiome studies. And don't forget that in addition to fecal microbiome, we are improving our knowledge on small bowel microbiome or oral microbiome, that I think is going also to be relevant to guide dietitians and to guide gastroenterologists in the use of probiotics, prebiotics, and diet-related modulation. Well, I would say that in the year 2000, nobody knew what the microbiome was, no? Well, nobody was using microbiome-based therapies, no? Now, I would say that most people is at least trying to use these approaches, no? And in my personal case, as I said before, I use them regularly. I believe I'm a believer, no? In the ability of probiotics, prebiotics, symbiotics, and all this stuff, and other interventions in improving the health of our patients, not only in treatment strategies, but also in preventive strategies. No, I think this is important for the patients. So in this sense, I have incorporated this, my routine practice, no? And I think this is non-stoppable. This is going to grow and grow and grow. Well, while it's difficult to predict, no, I think there are some areas that are very important. For example, no, as I said, standardization of the platforms, no, that this is something that has already begun, but we need to know which is a healthy microbiota, which is a disease microbiota, and this possibly will go also to the personal level, no, and this is going to be important. On the other side, I think we also need to know much more about interconnections between bacteria and other components of the microbiota, like fungi or bacteriophages or even parasites. No, this is critical to understand their role in managing disease. I always tend to think that health and disease is a balance between protective and aggressive factors. The dynamics of the microbiota is also another important issue. People is now worried about longevity, health, so we need to know the role of microbiota in that sense. No? We also need to understand the complexity of the microbiota, the relationships between gut microbiota and oral microbiota, or gut microbiota and skin microbiota.